Okay, good morning, everyone. My name is Dr. Bianca Hall. I'll be leading the breakout session today. So I'm going to get started. Let me just get everything in mode. So the title of today's breakout session is Saving Me from Myself. And this is just a discussion on the impact of racism on pregnancy and birth on Black women from the perspective of a Black woman physician, which would be me. So I wanted to make sure that you guys know that this is an informal discussion. I had the pleasure of being a part of the Racism in Medicine conference last year, and it was a little bit different naturally because we were not experiencing COVID. So it was really a great time where I was able to interact with you. You could ask me questions, I could ask you questions, and I want to try to simulate that as best as possible again now. So if you guys have any questions, feel free to engage in the chat and we can go from there. There is a portion of this talk where I'll be asking you questions, so feel free to unmute yourself and join in the conversation. I have no financial disclosures. I'm going to introduce myself. So I am currently a fourth year OBGYN resident at Cooper University Hospital in Camden, New Jersey. Because of that, I am still poor. So I don't have any financial disclosures at this time, but what I lack in finances, I have gained in wisdom and knowledge. Some of that I'll be sharing with you all today. I also was a medical student at Rowan University School of Osteopathic Medicine not too long ago. I graduated in 2017. And to be honest, it was there where I actually gained a lot of my interest in some of these topics, not because it wasn't my experience, but I grew up in the Washington, D.C. area. I'm a first generation American, Caribbean American. My family's Trinidadian and Guyanese. I also happen to speak the Spanish language because I lived in Honduras for a little while. So I didn't realize some of the barriers that people like me look like because I grew up in an environment where most of the people look like me. And it wasn't until I moved to New Jersey, interestingly enough, where I had an experience where I was truly an other. And I really learned how to advocate for myself and others while at RowanSOM. So I appreciate all of you all for going to this conference and taking the first step in trying to gain this knowledge. So the objectives for today, we're going to define maternal and infant morbidity and mortality, discuss the risk factors for complications during pregnancy and birth, evaluate the effects of racism on pregnancy and birth in the United States, assess the social determinants of health and ways that they impact pregnancy and birth outcomes, assess barriers to providing quality care for healthcare providers, especially providers of color, and discuss ways to implement advocacy strategies for patients and healthcare providers. And it's more so in these last four objectives that I'll be asking you guys to join in. But again, feel free to join in at any time. Sorry, guys. So I wanted to start the talk with this tweet. And I saw this tweet probably about a couple months ago in June, kind of when we were in the thick of things with what was going on with police brutality and racial injustices in this country this year, because as we know, it's cyclical. And when I saw it, my heart was broken because I had to reconcile the fact that the vitriol that I and many others felt around police brutality, many people feel about the care that Black women are receiving. And so the tweet says, what police do to Black men, doctors do to Black women. And I was hurt. I was so hurt because I was like, wow, that's me. That's me in so many levels. That's me as a Black woman. That's how I identify first. And then that's also me as a physician. And it's almost like I'm inflicting that pain on myself. I'm inflicting that pain on people that I love. And I don't want anyone to feel that way. So when I saw that, I think that's when the wheels started churning for me in a real sense in terms of how I can truly make a difference. not because I didn't know about maternal morbidity and mortality and its effect on Black women. I live that. I do that every day for work. That's part of the reason why I got into OBGYN. But understanding that that is the dichotomy of how people view it. People view it the same way that they do police killing Black men. I think it really was a pivotal moment for me in how I wanted to approach this topic with my work. And then shortly thereafter, my phone was blowing up again because this came out. And I'm sure many of you guys have probably seen this because it was headline news as well. Black newborns are more likely to die when looked after by white doctors. And this came out of a study that was done in Florida, and it was published almost everywhere, that looked at the mortality rate of Black newborns. And they found that it shrunk by about 30 to 50% when Black physicians were in charge of the birth, as opposed to when white physicians were. And interestingly enough, by contrast, the mortality rate for white infants was largely unaffected by the doctor's race. So here we have it in mainstream news in the most recent months that not only are doctors killing Black women, essentially doctors are killing Black babies. And so that's not going to sit well with anyone in the Black community. It doesn't also help, I guess, that a lot of celebrities have been speaking out lately about their experiences with the healthcare system and some of the inequities that they've experienced. It's very well known that Serena Williams had a lot of difficulties and challenges in the postpartum period receiving care when she delivered her baby, with being diagnosed with a venous thromboembolism. Beyonce also came out and spoke out about the fact that she had preeclampsia and was delivered via cesarean section when she had her twins. Recently, we were mourning the loss of Dr. Shanice Williams, who also happens to be a pediatrician. She was 30 years old and had a pregnancy course complicated by preterm delivery, allegedly what sounds like preeclampsia or HELLP syndrome, and ultimately that took her life. And then also in the fictional setting, I think this is the right demographic for this, because if you guys are like me, you are also pretty obsessed with Insecure by Issa Rae. And Tiffany, one of the characters there, kind of played out her experience as a Black woman giving birth. And she talked about postpartum depression. And also in one of the scenes, they took a deep dive into her experience with developing a blood clot, so she called it, likely a pulmonary embolism, and how she was ignored and had to beg for care while she was in the hospital. So unfortunately for Black women, this is inundating us everywhere. This is our real life. This is our gossip news with our celebrity news. This is what we're intaking on TV. And it's hard to escape it. Not necessarily because we don't want to face it, but we also want to feel like we can do something that's normal and natural, like childbirth. So we have to look at what the disparities are for us. Black women, according to the research, have disparities in infertility. We are often found to either have more likely to have issues with infertility and or have barriers to access to infertility treatments. We are at an increased rate for unintended pregnancy, inadequate prenatal care, pregnancy-related complications, some of which I've just spoken about, and we'll talk about a little bit more later. Preterm birth, lack of access to contraception, especially our preferred methods of contraception, and ultimately increased risk for maternal and fetal death, as well as neonatal and infant death. And so as we dig into this talk a little bit more, I want to make sure that we're using the right terminology and we're using the language that is found in the literature, because you'll see later there's some specific language that is used. And so we have to define maternal morbidity. That's any health condition attributed to and or aggravated by pregnancy and childbirth that has a negative impact on a woman's well-being. And then severe maternal morbidity is defined as the unintended outcomes of this process of labor and delivery that result in significant short-term or long-term consequences to a woman's health. Maternal mortality is the death of a woman from complications of pregnancy or childbirth that occur during the pregnancy or within 42 days after pregnancy ends. I have in parentheses up to 1 year because you'll also see the language of pregnancy-related death, and that is the death of a woman within this context up to a year after the pregnancy ends. So that's under the umbrella of maternal mortality. And then lastly, infant morbidity and mortality is a serious illness or death after birth of an infant up to the first year of life. I'm really going to focus more on the maternal side of things because as an OBGYN, if any of you guys have interacted with us as medical students, you'll know that we are all about the babies when they're inside, and then once they come out, we kindly hand them over to the pediatrician. So my focus is going to be about this experience of moms and the fetus. And so I also wanted to define, when we talk about maternal morbidity, what conditions we're actually talking about. And the conditions that come up most often are cardiovascular disease, infection or sepsis, hemorrhage, cardiomyopathy, venous thromboembolism, usually resulting in thrombotic pulmonary embolism, cerebral vascular accidents, hypertensive disorders of pregnancy, amniotic fluid embolisms, and anesthesia complications. And of course, there are other things that fall into this bucket as well, but those are some of the major conditions that we're talking about. And so risk factors that kind of are given to the general public for maternal morbidity and mortality are maternal age, greater than 35 years old, pre-existing conditions. So that's poor preconceptual health. So that's before you even conceive, before you get pregnant. If you have a condition that puts you at risk, the presence of comorbidities during the pregnancy definitely puts you at significant risk. Some aspects of the birth history put you at risk. So nulliparity, that is having never been pregnant before. Multiparity, interestingly enough, meaning that you've been pregnant multiple times, especially grand multiparity when you've been pregnant more than like 5 to 7 times. Multiple gestation, meaning that you're pregnant with multiple fetuses at the same time. And then a history of prior cesarean delivery tend to be the biggest risk factors. Of course, there's other parts of the birth history, like history of preterm birth before, et cetera, that will put you at risk, but those are some of the big ones. Socioeconomic status has been found to be a risk factor for maternal morbidity and mortality, such as low socioeconomic status, and then insurance status, meaning whether you are funded by the state or have no insurance at all. Geographic location, it's been well studied that unfortunately women living in the southern states are at greater risk for maternal morbidity and mortality. And race, as we've kind of clearly defined already. Minority women, especially Black women, Latinx women, Pacific Islanders, Asians, and Native Americans and American Indians have greater risk factors for just general morbidity and mortality. So we're going to focus more on the Black women's aspect of this. So in 2019, a great document was put out by the National Institutes of Health, the Office of Women's Health Research, put out a document looking at severe maternal morbidity and mortality, what's causing it and how to address it. And so what they found was that 50,000 women in the United States in 2014 were affected by severe maternal morbidity. The rates of this have actually nearly doubled in the past decade, which you can see the trend in the graph here. The most common indicator of severe maternal morbidity is the need for a blood transfusion, and that's fairly common, especially where I work. I work in Camden, New Jersey, with mostly minority women, and so that's something that happens a fair amount. And pregnancy-related death. So for every 1 woman that dies, 70 women experience a near miss, which is defined as a severe maternal morbidity. So that's a lot of women that are experiencing this. Who was affected by this? We see it mostly at the extremes of age. So women that are younger than age 20 or older than 40, as we talked about before, women with state insurance and found to be living in a zip code that overall has a low income. I want you guys to take a look at this map. I know we're probably all tired of looking at maps at this point with everything going on with the elections, especially the little color boxes. But as you can see, it's not only women in the South, it's also women living where we live on the Northeast. As you can see, the whole East Coast kind of has a higher likelihood of experiencing severe morbidity and mortality. If you notice, that's also where the highest populations of minorities exist, with the exception of probably California and Texas. And those two states have also done a lot of work towards improving their statistics and making task force for maternal morbidity and mortality. This document also points out that compared to white women, the incidence of severe maternal morbidity is significantly increased in certain groups. So it's 166% higher for Black women, 122% higher for Latinx women, 117% higher for Asian and Pacific Islander women, and 148% higher for American, Indian, and Alaska Native women. Those are significant numbers. Taking a deeper dive into this, Black women are approximately 3 to 4 times more likely to experience pregnancy-related complications and/or death than white women. And quite frankly, looking at the data, most other races as well. This was also looked at as a corrected for factors that we're told should make it better. So this is corrected for education and higher socioeconomic status, as we saw with the celebrities like Serena, Beyonce, and Dr. Williams. This did not mitigate the elevated risk of severe maternal morbidity and mortality among Black women. Even looking at women who are foreign born, so not born in this country, but still identifying in this ethnic group, they still had a 16.1% higher risk of death. And women that are greater than 30 had a 30% risk of pregnancy-related death of occurring. So looking at the trends and seeing how we compare to other countries in the world is also quite astonishing, because United States, which is supposed to be one of the superpowers in the world, is actually doing the worst as it compares to other developed nations. So each year, 700 women die in the United States as a result of pregnancy or delivery complications. Experts say that 50% of these deaths are actually preventable. And when you look at us, our rate is about 26, which is probably a little bit higher now in 2019, but this is the last time that we have statistics. We've increased 16.7%, as opposed to the rest of the world, which is actually going down. The world has gone down about 44%. So this is not only a cultural crisis, it is an epidemic, much like COVID, much like other epidemics that we've experienced in this country and in this world. And so ACOG, which is the governing body of obstetricians and gynecologists, wrote a committee opinion on this. As you can see from the dates, it was written back in 2005. And because it's such an issue, it's been reaffirmed and reaffirmed, most recently up into 2018. And the document itself is fairly good. It talks about things that obstetricians can do to help alleviate the racial and ethnic disparities. I'm going to talk about the good parts first, and then I'll leave the one part that I kind of have issue with for the end. So it talks about raising awareness among colleagues, residents, staff, hospital administrators about the prevalence of racial and ethnic disparities and its effects on health outcomes, understanding the role that the practitioner can play in bias and how that affects healthcare and health outcomes. It encourages the adoption of federal standards for collection of race and ethnic information and clinical and administrative data to better identify disparities, which is a huge problem that we have in healthcare. Promoting research that identifies structural and cultural barriers to care and tests the effectiveness of interventions to address these barriers. It talks about educating patients in a culturally sensitive manner about steps they can take to prevent disease conditions that are prevalent in their racial and ethnic groups. And it talks about supporting and assisting the recruitment of OBGYNs and other healthcare providers from racial and ethnic minorities in academic and community healthcare fields, which is crucial and awesome. So I applaud ACOG on the stance that they've taken on this matter. But as you read through the document, one of the things that I did not love was it was talking about how race affects the disparities. And it talks about how the frequency, and this is just a quote, the frequency of certain genetic variations may differ between racial or ethnic groups, but generally are related to common ancestral lineage. For instance, there's an increased frequency of mutations for certain genetic diseases in individuals of African descent. Genetic polymorphisms associated with increased susceptibility to disease also may vary in frequency in different racial and ethnic groups. And this is true. As a physician who's gone through medical school, we know that there are certain things that are more prevalent in certain racial and ethnic groups. But the document doesn't necessarily do well at calling out one of the biggest factors for the disparities that we have, especially in this country. And it's not necessarily race, it is actually racism. And so we have to ask ourselves, what is the true risk factor? Is there something inherently wrong with me as a Black woman? Or is there something that is wrong with my experience as a Black woman in this country that's causing me to go through the issues that I go through? And so the CDC did a little bit of digging into this, as have other groups. But they do a lot of data tracking, and they looked at pregnancy-related mortality ratios as it compares by state. And so they looked at the states with the lowest pregnancy-related mortality ratios, and they looked at medium states and high states, and they found that overall, regardless of where you were, Black women had about a 3 times higher risk for having pregnancy-related mortality than white women. So that speaks to more so of a systemic problem than an individual problem. They also looked at the disparities by educational level, and they found that Black women that are college educated were 5 times more likely to have pregnancy-related mortality than white women of similar education. And as you look at this graph, you can see that the gap actually increases the more educated we become. And those are the things that we've always been told. If we do this, if we move to the right areas, if we educate ourselves, if we change our socioeconomic status, those will help us overcome some of the social determinants of health that have held us back. But what we're finding through research is that that's not necessarily true for us as Black women. So what is the common experience that we all share? What is the issue that's causing Black women to have higher adverse outcomes? And what we're finding now through research, now that we have the lens and the data to look at this appropriately, is that racism is one of the major risk factors. I love this picture when I saw it a couple months ago because it really speaks to how we as Black women feel. We are not carrying for 9 months, then struggling during labor for 9 hours just for you to kneel on our necks for 9 minutes. And this is speaking to the death of George Floyd. But I also want to throw in a plug that 9 hours is a very short labor force, but that's neither here nor there. But what the research has shown us, and I just took out some of the key points from some of the studies that I've looked at, Black women, regardless of socioeconomic status, are more likely to have perceived stress. And I hate that word perceived because it makes it seem like it may not be true, like it's just unique to your experience. But Black women are more likely to live in stressful conditions. As we can see, this woman has to live in some element of stress because she's carrying a child and is not even guaranteed that her child is going to be able to live the life that she imagines her child to live. Her child may not even live the life that she lived growing up due to some of the racial climates that we're currently experiencing. Black women are more likely to have depressive symptoms, more likely to experience less social support, more likely to perceive lower quality of healthcare from providers, and I'll talk about that a little bit later, more likely to have limited access to resources, and then also likely to be affected by redlining and neighborhood segregation. And so these are things that are not happening because of us. This is not genetics. This is not something that I was inherently born with. These are things that are happening to us because of the social construct of race and how people perceive we should be treated because of that. And this was something that I see not only as a provider, this is something that I see as a patient and as my experience as a Black woman. So we're talking about intersectionality here. And for me, this is the crux of it, because I see this as I take care of my patients in Camden, which has one of the lowest social economic status in New Jersey. And I also see this as I look at my family and my friends, which is scattered throughout socioeconomic groups, which is scattered throughout educational groups. We all carry a certain level of stress. We all carry a certain level of racism with us that affects our experience. This was looked at and described as weathering by Dr. Geronimus in 1992. Her theory was that African American women, our health deteriorates in our early adulthood as a result of cumulative exposure to socioeconomic disadvantages and institutional racism. And there were subsequent studies that were done after this that supported her work. It's somewhat controversial amongst others, but I will have to say that in my experience, there's something to this. I see amongst my patients and my family and friends the lower quality of healthcare from providers. I think as a Black woman physician and as a resident, I try to make it one of my goals to provide quality healthcare for my for my patients. They talk often about the bias that providers have against Black women when we talk about our pain and how it's perceived and the care that we receive when we go to prenatal care in terms of offering us and instructing us on breastfeeding and things like that. Those are things that I have seen and experienced with my own eyes. I can tell you about a patient who was in the hospital for preeclampsia, severe preeclampsia, had pulmonary edema. The woman could barely breathe. She was very frustrated by her care because she felt like she wasn't necessarily getting the answers to what was going on. So she was aggravated and appeared frustrated. And I had to argue with one of our nursing staff because they wanted to call security and get a behavioral consult on her. Not necessarily because the patient was attacking them. She couldn't even breathe, to be honest. Her respiratory sats were like in the high 80s. So she wasn't necessarily attacking them physically, but she was somewhat verbally frustrated with them. And I was saying, instead of calling security and aggravating this situation, why don't we take the time to figure out what the patient is afraid of and what we can do to make her more comfortable? And with that approach, I was able to build the trust of the patient and get her to kind of work peacefully with the nursing staff. But it is those instances where Black women feel isolated and ostracized in their care. And that absolutely has an effect on how we do when we heal, how we do when we deliver, and how our babies come out. In terms of limited access to resources, it starts from the beginning and it goes to the end. We have limited access to resources for preconceptual care, regardless of socioeconomic status, especially as we look at reproductive endocrinology in terms of allowing us to even talk about infertility. Infertility is not talked about in our community the way that it is in other communities. It's generally believed that Black women are too fertile. And so there's instances where we're not getting access to the care that we need when we are experiencing those things. Or in some states, it's not made known that there are provisions in place for us to get infertility care. We recently had an issue at the hospital where we were, where we had a patient who had a complication from hydrosalpinx, which is a swollen fallopian tube. And instead of being recommended to go to REI, which is reproductive endocrinology, one of the providers tried to take care of it themselves. And ultimately the patient ended up with morbidity, ended up with a large surgery and removal of her tubes. Whereas in the state of New Jersey, they have built in a family access bill that allows most people to get some level of infertility care. So these are just some of the instances where, even though it's not intentional, or even though people aren't necessarily trying to provide a lower level of care to patients, it happens because there's a bias that exists. So this is a portion where I wanted to try to get some feedback from you all. to see what do you guys think are some of the social determinants of health that may be affecting Black women or women of color and the pregnancy and birth outcomes. So if anyone wants to tell me what your thoughts are, I would love to hear. Okay. It says that they're unable to unmute the attendees due to the large volume, but people should send responses in the chat. And it's okay. I know sometimes it can be intimidating to engage on these large Zoom meetings, but I would love to hear what your thoughts are on this because you all are the future of this issue. As future providers, albeit outside of women's healthcare, you all are going to be the gatekeepers for this. Someone said lack of legislation that promotes equal access to appropriate perinatal care. That's very, very true. Ooh, lots of responses now. Access, cost, rapport with medical field, absolutely. Access to nearby and quality OBGYN care. That's true. And that's something that I want to speak to as well, because most of the areas where Black women are seeking care are in urban areas where most of the tertiary centers are. So it's very interesting when we say lack of access to care. That's something that I've been struggling with as a provider because, especially in Southern New Jersey where I work, there's hospitals everywhere, but we're not necessarily providing quality care for these women. Zip code, assumption about insurance, very true. Lingering effects of the crack epidemic and decreased belief of Black women's pain. That's 100% true. And that's something that I struggle with. That's a bias that I have as a provider. We're ingrained as we're growing up in medicine that you have to stay away from certain pain medications and not give it to patients. However, it sometimes gets in the way of how we treat our patients, especially when there's already biases about whose pain is more significant than others. Someone said the history of mistrust with medicine. Very true. And that's something that I'm going to speak to a little bit later as well. Lack of continuity of care in underserved populations, especially for such a trauma sensitive time like pregnancy. That is excellent. A lot of times, patients who are seen in underserved populations are seen in federally qualified health centers or sometimes resident clinics like mine, and they change providers frequently. And that's one of the biggest complaints that we get from patients. They say that we see a different provider, we don't know who's taking care of us, and they don't necessarily like it. Lack of access to green spaces or recreational centers/gyms in communities. Very, very true. It's hard to make lifestyle changes when you don't have a lifestyle that's conducive to making those changes. Intimate partner violence. Very true. Stigma against certain things, i.e., if you seek mental health, you're weak. Very, very true. Mental health is something that is looked down upon, not only in the Black community, but I think especially in the healthcare community, we have a hard time grappling with mental health. So outside of our providers that work specifically in that, sometimes it's easily glossed over and overlooked. I know that's something that we struggle with in our clinic because you have about 10 to 15 minutes to see, to see patients, and to sit down and go through some of the full mental health screenings is a little bit challenging. Intersection of religion and reproductive control and stigma, absolutely. That's something that this country is definitely grappling with at this time. One of the things I didn't say when I was introducing myself is that I'll be a complex family planning fellow next year. So I am very passionate about reproductive justice, and how this country approaches reproductive justice is a disservice to most women, not just Black women. Someone said, I'm not a physician, but I study perinatal and aneuploidy testing. I'm interested in your experience as a provider. Do you feel that there are disparities in who is offered prenatal testing or who feels comfortable accepting prenatal testing? Absolutely. I think that in general, Black women are not offered prenatal testing. And that's one of the things that I actually read in the ACOG document, but I didn't go into because I felt like it was too much for the talk. They commented that prenatal testing is less received in the Black community because I'm going to paraphrase their words, but it was less understood and less appreciated. And I think that that's not 100% true. I think that as a physician and as a resident, I don't know that I was necessarily well taught on how to explain all of the genetic testing that we can offer and its benefits to patients. And so I think part of that is the issue. When you're talking to certain communities, you have to make sure that you're explaining it in a way that not only they will understand, but so that it seems useful for them. I think when you're talking to women of different educational backgrounds, they're going to understand prenatal aneuploidy testing in a way that's very different. And so I noticed that most patients that come and get care in our private offices will get the non-invasive prenatal testing, whereas our patients tend not to. There is some issue with coverage for sure, but Medicaid does cover some of the non-invasive prenatal testing. So there's absolutely disparities there. Someone said the assumptions made around teen pregnancy. I have seen too many providers assume the patient was irresponsible when sometimes these are cases of domestic violence. Very true. I once heard a speaker say that people look at the outcomes of a pregnancy and blame the person that is pregnant, whether it's good or bad. So if you choose to have a termination, people blame you. If your pregnancy turns out poorly due to comorbidities, people blame you. And they don't necessarily take into account all of the features that can go into that pregnancy. And so that's definitely a large bias that occurs. Lack of programs supporting Black women to become OBGYNs, healthcare advocates, or to pursue careers as physician/lawmakers in general. Absolutely true. And we're going to speak to that a little bit as well. So thank you guys for that. I appreciate all of the engagement that I received. We'll definitely have time for more questions at the end if you guys have them. I wanted to take some time to speak to the barriers to care that I face as a physician. And so some of you guys brought this up, lack of trust. There is a big breakdown in trust between physicians and patients. I hear it when I listen to the news. I hear it when I talk to my friends. I see it on social media. I hear it when I listen to podcasts. I was listening to a podcast as I was driving yesterday, and it was saying that physicians try to do more C-sections on patients because it's more convenient and we get reimbursed more. And I had to like clutch my imaginary pearls when I heard that, because I was like, absolutely not. I am one of the biggest proponents for allowing women to have a safe vaginal birth if that's possible. But those are just some of the things that patients genuinely think about us. There's been a big swing to have home births now, which is not 100% the worst thing. I know a lot of physicians feel differently about that, and it's a very controversial topic. But as a Black woman who's a little bit hippy dippy myself, I understand why women would want to have a home birth. One of my cousins actually had a home birth and it was uncomplicated and she did well. But my fear with that is there are a lot of women that are already at risk, that can put at further risk if we continue to isolate ourselves, meaning that there's this big gap between Black women who need physician care and the physicians that can provide care. There is a long history of ill treatment of Black women in obstetrics and gynecology that goes back to slavery with Dr. Sims, and then the experiments, Henrietta Lacks, even things that are happening today. So we have to find ways to build that trust again. One of the things that many people have instituted is finding other care providers outside of physician for their healthcare. So they look to doulas, and other community healthcare workers. And that can be a little bit tricky as a physician, I will not lie. Sometimes it's hard to manage care with so many different people trying to lead the team. But I think understanding where we are in our community with Black women and understanding the lack of trust that exists and understanding even just the fragmentation of care that happens with some of the healthcare systems that we have in place, we have to be a little bit more open to spreading the wealth and building the team that's appropriate for that patient. Because ultimately, if they trust us, we can provide them with the care that they need. The other barrier that I've noticed is limited resources. So as much as there's limited access to resources, sometimes there's just limited resources to provide. So even talking about breastfeeding, because there's an idea and a stigma around breastfeeding, especially in the Black community. And I never try to force my patients to do something that they don't want to do, but the research has shown us that breastfeeding is best for mother and baby. But some women really struggle with that in the beginning. Breastfeeding is not something that's intuitive for most women, but I don't always have the lactation consultants that I can send out. I don't always have some of the resources that other groups do. Even sometimes with social workers, trying to help patients around transportation and healthy living. WIC is a great resource for patients, but not every woman that is having issues receiving food and other things are even qualified for WIC. So those are all limited things that I want to be able to provide everything for every patient, but it's very challenging sometimes to do that. The poorly equipped workforce. And so that's something that many of you spoke about when you guys were bringing up your points about what are some of the social determinants of health. It's absolutely true that our physician workforce is not trained in the best way to take care of these patients. Cultural competency was a big thing. Now I think we're using the term culturally sensitive. I think cultural sensitivity is a huge aspect. Implicit biases and explicit biases run rampant in medicine. And if we don't start that training early, again, that's why I'm so proud of all of you guys for being here at this conference. If you don't start that training early, if you don't start framing your mind to be sensitive to the patients that you're going to take care of, then it will have ill effects as you move forward because you only get busier, you only get more tired, and your brain only becomes more focused on certain things. Currently, in terms of the Black women physician force, we only make up 2%. And so research has shown that women do better with providers that look like them, but there's only 2% of us out there. So we need people who don't necessarily look like us to step up and provide the care that is needed. And then lastly, it's burnout. Because only 2% of us exist, 2% of us can't carry the other 98%. And so a lot of physicians get burnt out and they really struggle to care for patients the way that they may even want to on the inside with all of the stressors of participating in medicine. I only have a few minutes left and I don't want to run over, so I'm going to try to move a little bit more quickly. So what can we tell our patients? Because the biggest thing patients can do in this setting is advocate for themselves. Of course, we as providers are going to do a better job of being an advocate, but there's nothing like self-advocacy. So you have to tell patients to know before you go. You have to do your own research. You have to look into the providers that you are going to see. Now, I'm sure there's patients who have probably written crazy things about me as much as I love patients, but you have to kind of do your own Yelp review and see where are you going and what is going to provide the best care for you. You have to create the team that works best for you. My friend Kristen and I, in response to the Insecure episode, we wrote an article for Health in Her Hue about how to advocate for yourself. And we said that if you go to a doctor and you feel like you're not getting the care that you need, then it's absolutely okay to get a second opinion. It's absolutely okay to find a different provider. Not every provider works for everyone. There's no love lost. You are not married to that physician. You have to create the team that works for you. And even if that means getting a doula, even if that means having a midwife, someone else to be on your team, do it. As a physician, I recognize the acute struggles that it can present to have many people on that team, but this is your experience, and no one can take charge of that in the same way as you can. Ask questions. I can't tell you how many times I talk to my patients, and at the end I say, do you have any questions? They say no. I see them the next week and they have no idea about what I said to them. You have to ask questions. You have to know your care. Unfortunately, like we talked about before, the way the medical system is set up, there are so many different moving parts. Sometimes you don't see the same provider within the same visit. You don't see the same provider when you come back to the same place. So you have to be the anchor and the cornerstone of your care. You have to understand what's going on. You have to ask questions. If you get told something by your provider and it doesn't make sense to you, you have to ask them, can you repeat that? Can you rephrase? These are critical things that patients should be doing to make sure that they are getting the type of care that they need. And you have to follow up. There are so many patients that I see that get lost to care. And I understand that it's difficult, especially when you have so many different social stressors, to sometimes put your care first, especially for Black mothers. But I always tell my patients, your family will not be healthy if you are not healthy. So following up is absolutely crucial. And yes, I will explain some of the stigma at the end. And so for physicians, for providers, it's important that we attempt to understand our patients. So even as a Black woman, I don't know every Black woman's experience. So it's important that I take the time to explore, to research. Even as a physician, I don't know all of the statistics. I don't know all of the data that's out there. So I have to take the time to educate myself and make sure that I'm understanding the experiences of the people that I'm taking care of. Exposing myself, not only just for Black women, because I take care of more than Black women, to all of the groups of women that I take care of, so that I can find something to connect with them on. Patients will come back to the physician that they connect to, regardless of their race. And so that's crucial. Not only does the patient have to ask questions, you have to ask questions. I drill this into my junior residents. Don't go by what's on the chart. You need to talk to the patient. You have to ask them what's going on in their life, not just their past medical history, not just their surgical history, not just the social history that includes smoking, alcohol, and drug use. Ask them what they do for work. Ask them how many children they have. Where does their son go to school? How are they coping with that? Someone spoke about domestic violence. You won't know if you don't ask. Most people are not volunteering that information. So you have to build a rapport with your patients. Stand up for yourself and your patients. That's something that's also crucial. That's the biggest part of advocacy. And advocacy doesn't just look like going to the Hill and lobbying and creating policy. Advocacy starts on a daily basis. Even as medical students, you can stand up for your patients. If you see something that's not necessarily going on correctly, bring it to the attention of the person above you. Talk to the resident, talk to the attending. Sometimes that can put you in sticky situations, but integrity is important. How you do it is important. I'm not telling you to roll up to the scene and cuss everybody out because you see something that was done incorrectly to a patient, but definitely make it a practice now to stand up for your patients and stand up for yourself. If you notice that you're in an environment where you're being treated incorrectly because of your otherisms, then most likely that's going to happen to the patients. And while people may not respond to you, they will respond to patient care because that is a big driver of the healthcare environment. And lastly, follow through. Just like the patients need to follow up, we have to follow through. We have to make sure that we're doing what we said we were going to do for these patients so that they can trust us and they can get the care that they deserve. I wanted to highlight two organizations that I love that provide great information on this topic. It's the National Birth Equity Collaborative. It was started by my mentor in my head. Her name is Dr. Joya Carrera Prairie. She is phenomenal and has done a lot of work around birth equity in the United States and reproductive justice. Black Mamas Matter Alliance is another group that's made up of a multidisciplinary team trying to improve the morbidity and mortality rate for Black women in this country. So if you guys have time, definitely spend some time looking up those organizations. And so ultimately, this is a big problem. It's an epidemic that we have in the United States. And for many of us, we're going to experience this as the provider and the patient. I think the death of Shanice Williams really hit me because that could be me. We're the same age. We are in the same profession. We're both physicians. And her life was still lost. So I don't know what's going to make the difference for us 100% yet. But I know that if we keep working towards it, we can get there. And so thank you guys for coming. I want to spend a little bit of time. I'm 4 minutes over, but I want to spend probably 5 minutes taking questions. I have one question here that says, if there's time, could you explain the stigma of breastfeeding in the Black mothering community? Absolutely. So there's a lot of stigma around breastfeeding that exists for many reasons. One of the reasons that we've identified is going back to the slave times where many Black women were wet nurses. And so they weren't even able to breastfeed their children. They were used as tools to breastfeed other people's children. And so although that's not something that women will say by name today, we believe that that's part of the issue that exists currently with breastfeeding. There was also a big pendulum swing towards bottle feeding, where that was a sign of status, where women were taught if you had money, you can afford the bottle. And that exists not only with Black women, that I see that a lot in my Latinx community too, where some of them feel like it's more prevalent to bottle feed because breastfeeding meant that you were poor. In addition, breastfeeding is hard. And if you don't have someone in your life to coach you on it, so if your mother didn't breastfeed or your sister didn't breastfeed, then you don't necessarily have someone in your life to show you how to breastfeed. So some of it is generational. So what we see now is there's a big swing, especially for my patients of lower socioeconomic and educational status, to say, I'm not going to breastfeed. Or they try to breastfeed while they're in the hospital and it hurts and it's hard, so they don't do it anymore. But again, the American Academy of Pediatricians and ACOG are big supporters of breastfeeding. We see that it has great impacts for children as well as for mothers. And so it's something that we do try to push them towards if we can. There's another question that says, what is something you would like to see incorporated in the hospital you work in to address disparities in OBGYN healthcare? I think in my hospital, we're trying to do a lot right now around anti-racism work. We actually started an anti-racism task force in our OBGYN department to look at some of these things. I think for us, we have to do a better job of just looking at our data. I anecdotally see a lot of disparities that exist with our racial groups, but I don't think that we're doing a great job of capturing it on paper. So I think that's one of the first things that we can do, because medicine is data driven. If it's not documented, it didn't happen. So making sure that we're documenting it. I think for the population that I take care of, I would love to see us get some more transitional navigators, some more social workers, and doulas. The next question is about doulas. Camden actually has a program where any woman that is a resident in the city of Camden has access to a doula. And that's something that I would actually love to see, because I know as a provider for women in Camden, the doula is the constant for them. I occasionally get to see the same patient throughout the course of their pregnancy, but that's not always the case. And that's often the case for patients who go to federally qualified health centers or centers that mainly take Medicaid, just due to the schedules of the providers that are there. So if we can create environments where patients are building a trusting, caring healthcare team, I definitely think that that would impact the care that they receive. The next thing says, I know data has shown that doula/continuous labor support benefits Black mothers, but do you notice anecdotally if the effect is more dramatic when the care team is led by a white doctor versus a Black doctor? I think anecdotally for me, the care is different when patients have a Black doctor. And it's not because my white colleagues or colleagues of other races are bad. I think all of my colleagues intend to do the right thing by patients, but there is a safety that patients feel when they see someone that looks like them. And that's something that I have too, even as an educated physician. When I go to a doctor that looks like me, I don't have to code switch. I don't have to put on, I don't have to say something or be someone that I'm not. And I think that that is something that patients feel as well. I know, like, I will tell a patient, like, I'm gonna just keep it a buck with you, right? Like, that's something that I can say to my patients that they're gonna understand and they're gonna appreciate that Dr. Hall is keeping it a buck with me. And they know that I mean well with them when I'm telling them certain things. So I think anecdotally, the care is different. In terms of doulas, most of the doulas that I've noticed come into the hospital have been Black. I have not seen a white doula with a Black patient, so I can't speak to that. But I think doulas in general are a great practice because whereas even just in the hospital, we're in and out of the rooms, the doula is with that one patient the entire time. And I think that I've seen most of the patients that have had doulas have had vaginal births. There are a few patients that have come in with doulas that haven't, or have come in with doulas that have tried to do things at home and have ended up having complications. So I think that you have to do your research for your doulas just like you do for your doctors, and making sure that you're getting someone who's trained and experienced, but they've actually made a great impact on Black maternal health. So it's 10 o'clock. If you guys don't have any more questions, it was great talking to you. I will leave my email address in the chat if anyone wants to ask more questions. This topic is so huge and there's so many things that could be said, but I hope you guys learned something today. And it was great talking to you. These are the references, just some of them.